Hello guys, let us today study about varicose veins. Varicose veins is a very common disease or complaint that is seen in OPDs. So it is a penalty of erect posture of human as it is not found in other animals. So this can be a disadvantage for erect posture, but yeah, there have been many advantages also. So not a big deal. A vein is called varicose when it is both dilated and tortuous. Other sites where varicose veins are seen are spermatic veins, where it is called varicocele, or esophageal veins, where it is called esophageal varices. There are also hemorrhoidal veins, vulval varices, etc. The varicose veins occur due to incompetence of venous valves. Etiology is it occurs in persons with long standing hours at work, for example, like bus conductors, policemen, petrol bunk workers, drivers of trams. Women are also affected, but the reason is progesterone, which is linked with the disease. Other causes the tone and contractility of the muscle of the lower limb being encircled by a tough deep fascia. Other etiology is AV fistula. AV fistula is arteriovenous fistula. The causes of incompetence of valves are many, which can be venous thrombosis, maybe tumors, maybe abdominal fibroid, ovarian cyst, abdominal lymphadenopathy. Pregnancy can also lead to varicose veins. A loaded colon can lead to a varicose veins. Retroperitoneal fibrosis can also lead to a varicose veins, and ascites can also lead to a varicose veins. History and examination. History. Age is you can say good deciding factor because it is more common in middle age, but it can affect all the age groups. The ratio between women and men is 10:1. See the ratio 10:1. Ethnic group. It is seen less commonly in primitive civilizations. It is related to the occupation which we have seen. Prolonged standing, for example, tram drivers, policemen. Individuals involved in excessive muscular contractions, for example, rickshaw pullers and athletes. The clinical features are it may be asymptomatic or dilated veins in the territory of long and short saphenous veins. Pain can also be a symptom which is mainly psychological, but yeah, these patients have some degree of pain which is aching sensation. Contrasting feature is bursting pain which is seen in DVT. The pain is particularly towards the end of the day. The pain gets worse when the patient stands up for a long time and is relieved when he lies down. Night cramps may also be present. The ankle may swell towards the end of the day. Itching in skin of the leg may be there. Skin discoloration can be there. The varicose ulcer, which is a complication of varicose vein, can also be seen on the medial malleolus. You should also inquire about the past history, past treatment for varicose veins, or any other history for surgery. Personal history. Women should be asked about obstetric history, like details of previous pregnancies and contraceptive pills. Family history is also important because it is found to run in the families. Now on examination, inspection is equally important. So, first we'll see dilated tortuous veins, which can be in the territory of long vein or short vein territory. In long vein territory, it is seen on the medial side of the leg, starting from in front of the malleolus, medial malleolus, to the medial side of the knee and along the medial side of the thigh upwards to the saphenous opening. The short saphenous vein territory is in the leg from behind the lateral malleolus upwards in the posterior aspect of the leg and ends in the popliteal fossa. Let us see some pictures of varicose veins so that you become familiar with the disease and easily diagnose it. So, these are skin changes. This is skin pigmentation. Lipodermal sclerosis is also present, and you can say this is coming from anterior and going here. This one is going here. Again, there is dilated tortuous vein. So the first thing is it is dilated and tortuous also. So you have made a diagnosis of varicose veins. There is dressing because there was an ulcer, so it is a complicated varicose veins. More clearly we'll see this. Okay, from anterior side, if we trace the long saphenous vein, it should have been like this and should have gone here. This is anterior. Okay. This is the short saphenous vein territory behind the lateral malleolus, going up and ending into the popliteal fossa. There is no doubt in the short saphenous vein territory. But in this, it is not usual long saphenous vein territory. This vein, it should have been here. So this can be a short segment of a vein in which there is incompetent perforator or something like that, and which has caused the dilated tortuous veins. The perforators can be remembered as CBD. Okay, from below upwards, C for cocket perforators, which are 3 in number. First one is 5 cm above medial malleolus. The second one is 10 cm above medial malleolus. The third one is 15 cm above medial malleolus. The second perforator, which is boys, is just below the knee joint. The third one is Henterian canal perforator, which is also called as Dot's perforator. It is palm breadth above the knee joint. Some ankle perforators are also there, which are inconstant. They are called May or Custer's perforators. Short saphenous vein perforators are also there, which are not named. The swelling, which may be localized or generalized. Localized one is a segment of superficial vein or whole trunk of venous system, either long or short saphenous, can be dilated. In generalized one, swelling of the leg is mostly due to deep vein thrombosis. If there is DVT, the swelling will be generalized. Now we have to look upon the skin. We will look for the color. There are two terms which are important: phlegmasia albadolens, which is white leg. This is due to excessive edema or lymphatic obstruction with occlusion of major draining vessels, mainly veins, like iliofemoral thrombus. Pulse may be palpable in this case. The other term is phlegmasia cerulodolens. It is cyanotic mottled skin. Skin becomes congested and blue as a result of massive edema or occlusion of not only major vessels but also the collateral ones. So ankle pulses may also disappear and this may lead to venous gangrene. Texture should also be seen. Skin may be stressed and shiny due to edema following deep vein thrombosis. There can be eczema or pigmentation around the medial malleolus. Venous ulcer can be seen. Scar due to healed venous ulcer or previous operation for varicose veins can also be seen. Loss of hair or increased brittleness of nails due to chronic varicosity, which may indicate impending gangrene, can be seen. Now there are many tests for incompetent perforator or saphenofemoral junction. We'll do mainly 4 tests: the Trendelenburg 1 test, the Trendelenburg 2 test, the modified Perthes test, and the multiple Tourniquet test. But you should know what are these tests. For SFJ incompetence, you can do Trendelenburg 1 and Morrissey Coffin-Pulse test. For perforators, Trendelenburg 2 can be done, single Tourniquet test or multiple Tourniquet test could be done, PET test and Fagan test can be done. For DVT, Perthes, modified Perthes, Moses and Holmes test. Let us look upon this. After that, we'll see the videos. In first test, the Brody Trendelenburg test, the patient is first placed in the recumbent position and his legs or her legs are raised to empty the veins. Milking can also be done. Milking means emptying the vein by milking the vein. The SFJ is compressed with the thumb or tourniquet just below the saphenofemoral junction, and the patient is asked to stand up quickly. I'll show the video. In test 1, the pressure is released quickly. If the varices fills very quickly by column of blood from above, it means the incompetency of saphenofemoral valve. This is called positive Trendelenburg 1 test. In the second one, the pressure is not released but maintained for about 1 minute. Okay, the gradual filling of the veins during the period indicates incompetency of the communicating veins. First we see the video. Trendelenburg 1 test. See, this is milking is being done. Okay, the veins are being emptied by milking. Then tourniquet is being tied just below the saphenofemoral junction, and the patient will be asked to stand up, and we will open the tourniquet. See, we'll open the tourniquet and we'll look for the filling of the veins. See here, it is filling from above downwards, and here it is also getting dilated. Okay, see here. So it means incompetency of saphenofemoral junction. Now we'll do Trendelenburg 2 test. Again, we'll tie just below the saphenofemoral junction. We'll ask the patient to stand up, and we'll keep the tourniquet for some time, and we won't remove it for 1 minute and see the filling. If it is still filling, it means perforators are incompetent. See here, tourniquet is still there and they are filled. Here again. So what does it mean? It means that perforators are also incompetent. SFJ, we have seen the incompetency, so it is SFJ incompetence with perforator incompetence. So we have seen the perforators and SFJ, but we have not seen the location of the perforator कि कौन सा involved है या नहीं है. So tourniquet test is done to see the location of the perforators. इसमें क्या करते हैं? The tourniquet is tied around the thigh or the leg at different levels This is multiple tourniquet test. After superficial veins have been made empty by reading the line, you know that. The patient is now asked to stand up. If the veins above the tourniquet fills up and those below it remains collapsed, it indicates the presence of incompetent communicating veins above the tourniquet. So, I'll show you the video. Multiple tourniquets have been tied at different levels. One at the ankle, second at, you can say this is 10 centimeter, 15 centimeter from ankle joint. This is just below the knee perforator, just below the knee perforator, and this is just above the knee perforators. So if prominence appears here, so this perforator is incompetent, नीचे वाला is fine. यहाँ पे मिलता है तो this is incompetent, नीचे वाला is fine. Let us continue. See this. Okay, see this. Here is the swelling. Below it there is no swelling. So the incompetency of perforator is between these two tourniquets. So it means ankle perforators above 10 centimeter. Malleolus is incompetent. Here again you can see, so you can see 15 centimeter wala also is incompetent. यहाँ पे मिलता तो we could have said यहाँ पे है थोड़ा सा below knee perforator is also incompetent. वीडियो में ऊपर वाला है, we can't see क्योंकि वहाँ पे कुछ था नहीं, इसलिए we didn't make that appear in the video. After that we'll do Perthes test. I am not including the video because this is not done nowadays. In this, affected limb is wrapped with a elastic bandage. The patient is instructed to move around and exercise. If there is severe crampy pain, it is suggestive of deep vein thrombosis. In modified Perthes test, what we do is a tourniquet is tied around the upper part of the thigh. In this, we do not milk the vein. Tight enough to prevent any reflux down the vein, the patient is asked to walk quickly. If the communicating veins and the deep veins are normal, this is mainly for deep venous patency. The varicose veins will shrink, whereas if they are blocked, the varicose veins will be more distended. Let us see video. Okay, the veins are not milked. This is dilated, and the tourniquet being tied. This is dilated. This is dilated. Here you can see, and the patient is asked to walk, and we'll see whether the size of the veins are getting decreased or not. The videos have been slowed down. The patient was moving more quickly than this. And we can see it. So this is quite reduced in swelling and size, you can say. It means the deep venous system is normal. The importance of this test is to check the patency of deep venous system. If the deep venous system is not okay, we will not operate a patient of varicose veins because the only draining channel is superficial vein in that case. But if these are patent, so we can proceed with the surgery. Other test is a Schwartz test. I am not including the video, but you should know how they are done. I mean, at least theoretically. In a long-standing case, if a tap is made on the long saphenous vein, or long saphenous varicose vein, the lower part of the leg, an impulse can be felt at the saphenous opening with the other hand. So, if a long vein is identified and if we tap at the one end, the other end can be felt pulsating. The breath test. This test is performed to know the positions of leg perforators. Firstly, an elastic bandage is applied from toe to groin. A tourniquet is then applied at the groin. This causes emptying of the varicose veins. The tourniquet is kept in position and the elastic bandage is taken off. Understood? The same elastic bandage is now applied from groin downwards. अब क्या होगा? At the position of perforators, blowouts will be there or visible varices can be seen. There is one more test, Morrissey cuff impulse test. Limb is elevated to empty the varicose veins. The patient is asked to cuff forcibly. An expansile cuff is felt in the long saphenous vein, particularly at the saphenous opening. If the saphenous femoral valve is incompetent, I could not elicit this test, so I have not made a video on this. There is one test, a Fagan test. In long standing posture, the places of excessive bulges within the varicosities are marked. The patient now lies down. The affected limb is elevated to empty the varicose veins. The limb is then palpated along the line of the marked varicosity to find the gaps in the deep fascia. So if there is a gap in deep fascia, that is a site of perforator. We should also look for the signs of chronic venous hypertension, which are pitting edema. If there is pitting edema in a varicose veins, it also means there is chronic venous hypertension. If there is skin thickening, again a sign of chronic venous hypertension. If redness and tenderness, again a sign of chronic venous hypertension. If there is lipodermal sclerosis, which occur due to sclerosis of the skin and subcutaneous tissue, which is due to fibrin deposition, the tissue death and scarring occurs, is also a sign of chronic venous hypertension. In percussion, you have seen Schwartz test. If the most prominent part of the varicose veins are tapped, an impulse can be felt by the finger at saphenous opening. On auscultation, you can listen machinery murmur if there is AV fistula in a varicose veins. Regional lymph nodes can also be palpated if the patient is having a varicose ulcer associated with the varicose veins that had led to infection. So, lymph nodes can be enlarged. Abdominal examination is also important because you should look for the pregnant uterus in female, a pelvic tumor or lymphadenopathy to rule out the secondary cause, you can say. Investigation which are required are a routine investigation like CBC, LFT, KFT, chest X-ray for PAC workup, blood grouping again for PAC workup, ascending venogram can be done, descending venogram can be done, but these are invasive procedures, so not done nowadays. Less likely to be done. The most important investigations nowadays are either Doppler, which can be handheld, or the routine one, and the duplex ultrasound. These are the best ones. Treatment. We can manage a patient of varicose vein either conservatively or surgically. The conservative method includes limb elevation and the compression stockings, which can be graded. Asymptomatic cases do not require any treatment. Mainly compression stocking can be advised. If they are secondary varicose veins, like due to deep venous thrombosis, pregnancy, pelvic tumors, AV fistula, you have to treat the cause. Now we come to the surgical treatment of a varicose veins. So I have made a table for this, so to remember it easily. If we want to treat saphenofemoral incompetence, we should do Trendelenburg surgery, the first surgery, or we can do the flush ligation of the saphenofemoral junction for saphenofemoral incompetence. If we want to treat perforator, we can do it by subfacial perforator ligation, or if we do it endoscopically, it is called subfacial endoscopic perforator surgery. For small veins, we can directly inject sclerosant agent into the vein, which is called sclerotherapy, and fluidectomy can also be done. For dilated veins, more larger veins, you can see stripping along with the flush ligation can be done. Flush ligation, why flush ligation should be done? Because dilated veins along with SFJ incompetence. EVLA can also be done, which is endovenous laser ablation. Radio frequency ablation can also be done. The red ones are the newer modalities. Thank you so much.